Welcome everyone to today's webinar, Beyond Enhanced Recovery After Surgery, Employing Opioid-Free Pain Management in the Surgical Setting. I am Brian Zimmerman with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We're looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenter. We are thrilled to hear from Dr. T.J. Gann. Dr. Gann is a professor and chairman for the Department of Anesthesiology at Stony Brook University Renaissance School of Medicine. At this time, I'm pleased to turn the floor over to Dr. Gann to begin today's presentation.
Thank you very much for that very kind introduction, Brian, and good afternoon, everyone. I'm at the East Coast time, so I'm just past 12, and you may be at a different time zone. I'm delighted and excited to be with you today because we're going to talk about a topic that is, I hoped, would be of interest to you because this is something that is changing rapidly in the perioperative surgical field, and we're going to talk about enhanced recovery. In my hospital now we have about 6 programs now that are ongoing on enhanced recovery, another 2 or 3 which are currently being developed. So certainly it's a new way to look after patients, and I would like to share with you, some of our the studies and on enhanced recovery, and also particularly the use of opioids in this context of enhanced recovery. So without further ado, I'm going to advance to the next slide. So this is a disclosure slide that this program is funded, supported by Mallinckrodt Pharmaceutical. It is an educational program and is consistent with the FDA guidelines, and the information that is shared today is really for educational purposes, and there is no obligation on purchase or prescription of any of the drugs by Mallinckrodt or any other companies. So I would remind you, to those who are online, to fill in this sign-in sheets so that you can make a record of attendance. So you will probably be handed the sign-in sheets by the representative. All right, so let's first of all review the objectives of this afternoon's presentation. So first of all, we will discuss the prevalence of postoperative pain and how do we manage postoperative pain in today's healthcare and as well as today's practice. And then I will describe some of the potential benefits of reducing opioids, as well as the multimodal approach that we currently recommend for managing post-operative pain. And then share with you some of the experiences that having adopted or launched enhanced recovery when I was at Duke University, probably 7-8 years ago now, and just share with some of the lessons learned from implementation of enhanced recovery. Because although it is easy to say that I'm going to start enhanced recovery, but there is a lot of, issues related to the implementation, which hopefully we will have some time to discuss. So I start off with this slide because I think it's important to understand that while opioid-free analgesia may be a goal for our patients, there are still a role for opioids. There's a place for opioids, as in any situation, there's a place for opioids and non-opioids, but what we're trying to do is to rationalize the use of opioids. And if for some reason non-opioids cannot achieve what we want to keep our patient comfortable, certainly opioids has a significant role in the rescue setting. So how do we think about pain management in the context of enhanced recovery? Well, if you think about when patients come for surgery, before even the patient comes to the hospital, they will see a number of people, from surgeons to pre-op screening clinic personnel, even before they get to the hospital. So I think it's important that patients are educated about pain management even before coming for surgery. And as they see preoperative screening clinic care provider, often most of our information and education is shared with patients in that scenario. So they've got to understand what are our aims about their pain management. And the aim is really to try to manage the pain as best as they can, at the same time minimize the side effects of the medication that we provide to provide the best outcome. So that really is the objective. And sometimes total pain-free is not the main objective of postoperative pain management. Then they come to the pre-op holding area on the same day of surgery. And again, there is opportunity there to, again, educate the patients, remind them what the aim of the pain control is, administer some of the non-opioid multimodal analgesics, and at the same time, when they are in surgery, we do a number of steps to potentially reduce post-operative pain. And once they get to the recovery room, that is when they will tell us how well our prophylactic pain management strategy work. And then if they need further analgesia, we could provide that. And if they have significant pain, we'll manage that. So you can see that it is not a post-operative event. It is really a pre-operative, pre-admission in the recovery room as well as beyond recovery room. It is throughout the whole surgical continuum. So pain management is probably one of the most important elements of enhanced recovery. So let's take a look at how do we do currently. So this is an interesting slide because it shows 3 studies that were done over the period of about 20 years. The first study was done in 1995. The next one is about 6, 7, 8 years later, 2003, that was reported. And then the following one was published in 2014. So it's about a space of 20 years. And the study was actually a very simple study. And the aim of the study was to ask patients, how was your pain experience after surgery? And as you can see, represented by the different colored bar, the first study followed by the second study and the third study. And most of these patients had pain. 70, 80, 90% had pain after surgery. But what is more alarming is that there are about almost 50 patients that said their pain was moderate in nature. And another roughly 30% of the patients said at some point during their recovery, their pain was either severe or extreme. And this is where I think we can do a better job to reduce the number of patients with severe and extreme pain more into the moderate and slight pain. And again, you can see that over the last 20 years, even though these are different patient population, but we still have a significant opportunity to increase or improve pain management. So let's talk a little bit about how does one go about with improving pain management. Now, in the past, the model for pain management is really relying on opioids almost exclusively to treat patients' pain. And if you have slight pain, I give you some opioid. If you've got more pain, I give you more opioid. If your pain becomes extreme, I give you even more opioid. And that has been the traditional model of pain management. So moving to the present, now we advocate the use of multimodal analgesia, or MMA as an acronym, in the context of enhanced recovery. And the purpose of multimodal analgesia is this, that you try to use a number of different non-opioids and combine them, because we know that by combining non-opioids, you provide a much better efficacy. Combining different class of drugs, some of them are additive and some even synergistic. So that is really the current model. Now, going into the future, I think we can still adopt not only for multimodal analgesia with enhanced recovery, but even towards achieving an opioid-free analgesia. And this opioid-free term, has been very popular lately. And again, the concept is not so much totally avoiding opioid, but can we try to achieve analgesia without using opioids and use opioid more of a rescue? So let's take a look at, in the past, what has been the model. So as I mentioned earlier, that we use opioid predominantly in the past, that mild pain, I give you some opioid. Moderate pain, I give you even more opioids. And if you have severe pain, I just add on more opioids. And that really is not the best strategy to manage postoperative pain. Now let me show you a study. So this is a study that I had the pleasure to work with a number of my colleagues, and really to see that how do people decide whether they give themselves a dose of opioid in the context of patient-controlled analgesia. So we know that post-operatively, we give patient a PCA, patient-controlled analgesia device, and we say to the patient and say, press the button when you want to give yourself a dose of painkillers. Now, when you ask the patients, and often I was called to see the patient, let's say Mrs. Smith, who complained to the nurse that I have 10 out of 10 of pain. But when I see Mrs. Smith, and she has got a PCA button in her hand, and then when I looked at the PCA pump, the last time Mrs. Smith had pressed the button is almost an hour ago. So I would then ask Mrs. Smith and said, you know that you have a pain button and you can give yourself a dose of painkillers when you have pain. And she said, yeah, I know that. And then when you ask her why you haven't pressed the button over the past hour, then you will begin to hear that, well, I really don't like pressing that button because it makes me drowsy, it makes me sick. And you begin to hear why Mrs. Smith does not want to press the button, even though she's complaining of pain. Because she gets side effects, adverse events when she pressed the button. So most of our patients who has a PCA, they, in a way, trade off between pressing that pain button, which we're going to provide them with pain relief, and at the same time, they may experience side effects. So when you ask patients about how do you trade off, so when we give them a scenario, say that, well, if you press the button, let's say, for example, you get good pain relief, at the same time you get moderate vomiting, how would you trade that off? Would you press the button to get a good pain relief, or would you not press the button because otherwise you get moderate vomiting? It's interesting that most of the patients, they would prefer not to have side effects. Likewise, no constipation with fair pain relief versus moderate constipation with good pain relief. Again, not invariably that the patient weigh the side effects and pain relief. So that tells us that it's not because the patient didn't want to press a button and get best pain control, but they have to balance between pain relief and the side effects because of the opioids that they administer on the PCA. So that is where we, I think, have an opportunity to say, how can we provide better pain relief with less side effects? Now, another study that was conducted over 10 years ago now, that looking at patients who were given 3 different medications. The first group was given fentanyl. The second group was given esmolol, which is a beta blocker. And the third group was given remifentanil. So they had their anesthetic pretty standard, so they get 1 mice per kilo of fentanyl up front, they get fentanyl boluses, and then after surgery, that group would get fentanyl. And then the other one where they get esmolol induction, esmolol infusion. And the third group get remifentanil infusion. So the result is really interesting because you would think that the group that receives fentanyl or remifentanil would be the one that need less opioids or less pain post-operatively. But on the contrary, it's the group that receive esmolol that actually receive less post-operative opioids. And you think, why would that be the case? Well, there is this phenomenon of what we call acute tolerance. And this has been demonstrated in many studies where patients who receive opioid, contrary to what you think that they will receive less opioid because they already receive opioid intraoperatively, they may not necessarily receive less opioid. In fact, if anything, they receive even more opioid because of acute tolerance. And this has been more so with the more potent opioids such as remifentanil. You can see that in this slide, it shows that the fentanyl required in the package was highest in the remifentanil group, followed by the fentanyl group. In fact, the esmolol group received the least amount of rescue fentanyl in the recovery room. So that is another thing that we need to be cognizant about. Giving more opioid intraoperatively may not necessarily be the good approach. All right, so let's see, how can we then do a better job? Well, the use of multimodal analgesia is the one that I think I want to spend some time on because this is where we can do a better job. Let me share with you, this is a very large study, over 500,000 patients using a database, a premier database, and the study is fairly simple. The objective is to determine whether the number and the type of analgesia associated with opioid prescription complication and resource utilization. So in other words, they look at this large number of patients who had hip replacement and who have received either multimodal analgesic approach or just many opioids. And they compare these two groups. And what they found is that those patients who had hip operation and received multimodal analgesia achieve a much better post-operative outcome. The incidence of opioid-related adverse event was significantly less. 19% fewer GI complications, 26% fewer respiratory complications. They stay in a hospital fewer days, 12% decrease in length of stay, and they also have a lower incidence of opioid prescription, 20% fewer opioid prescription. So you can see that by using multimodal approach, you can achieve significant advantages and improve outcome, not only in reducing side effects, but it also reduce length of stay and you use less opioids. So that tells us that multimodal analgesia really should be the cornerstone of our pain management strategy in the patient that we treat every day. And enhanced recovery, which has been popular over the past 10, 15 years, really is trying to say, how can we best manage this patient with the current evidence that we have? And there's ample evidence that multimodal analgesia works. Combining 2 or 3 different opioids will reduce the side effects of opioid, reduce the amount of opioid, and improve post-operative outcome. Enhanced recovery gives us a great opportunity to use opioid-sparing techniques to reduce opioid exposures. So this study looked at what is the implication of implementing an enhanced recovery protocol in a typical hospital that you may be working in, and to see what if I have an enhanced recovery protocol and I implement it, right? So they look at their outcome before the implementation of enhanced recovery, and then they also look at following enhanced recovery, what is the outcome of these patients. So 1 year prior to the implementation and 1 year following enhanced recovery implementation. So this is something that you can do in your hospital, this pre and post study, which is commonly done, to look at what is the impact of establishing an enhanced recovery protocol. And what did they find? Well, the result is pretty amazing. That they show a cost reduction, 17% reduction in total direct pharmacy costs. Even though in this enhanced recovery protocol, they may be using more expensive drugs. They may be using IV acetaminophen. They may be using alpha-2 agonists. They may be using more peripheral nerve blocks compared to the opioids or non-enhanced recovery group. Despite using these drugs, they were able to show a reduction in pharmacy costs. And with that, they also saw that there is a 40% reduction in median length of stay. 40%, that is pretty significant. So if you have someone who stays for 5 days now, you can reduce it to 3 days. And we know that each day in a hospital will cost an average between $1,000, $1,500 to $2,000 a day. And they also show a reduction in opioid requirements, 71% fewer morphine equivalent doses. And that is where the patient get less post-operative ileus, they get less post-operative nausea and vomiting, and therefore they can get out of hospital quicker. So I can, again, the enhanced recovery study that we did when I was at Duke, very similar data, very similar outcome, and I would say that if you were to launch an enhanced recovery or implement enhanced recovery, you see very similar results. All right, let's talk about the future, because yes, what we are doing now, I think we are doing a much better job than previously, but going in the future, how can we further improve our pain management within the perioperative setting? Now, as I mentioned earlier, that integrating opioid-free approach with enhanced recovery is what we are trying to achieve. So in other words, can we avoid opioid as a first line? And maybe that use non-opioids and then use opioid more as a rescue. Why? Because we know that opioid increase the incidence of adverse events because of the side effects. We know that immediately post-operative opioid can result in acute tolerance and therefore post-operative hyperalgesia. And this potentially may result in a longer-term chronic pain. And then in the long run, this tolerance can also result in more pain that is more difficult to manage in the long term. And also, it may run the risk of persistent opioid use. which compound onto the current opioid epidemic that we are experiencing in this country. Now, I would say again that while the ultimate goal of this effort is to achieve opioid-free analgesia, but opioid still has a place in pain management. And we need to use it rationally, but opioid has a place because opioid still has there is no ceiling effect on the pain, whereas most other drugs has a ceiling effect, but we just need to use it appropriately. So where do we have opportunity to adopt opioid-free analgesia? So in a way that we can think about opioid-free at every single steps along that patient journey, intraoperative, postoperative, and beyond. So let me show you these three data sets. So these three studies look at retrospective group of opioid-naive patients. So these people have never used opioid in their life, and then they had a surgical procedures. And what they found is that there is a significant percentages of these patients continue to use opioid following that acute episode of opioid use after their surgery. These are pretty large patient populations ranging from 36,000, 39,000, 88,000. And we see that on the last column there, new persistent opioid use. Anywhere from 3 to 7% of these patients who have never used opioid in their life, now they become persistent opioid user. So we, as the perioperative physicians, perioperative care provider, may be contributing to this opioid epidemic, because you see that up to 6-7%, and some study even up to 10% of patients continue to use opioid a year after the surgery, where they never used opioid in the past. So something to think about. Now, the implementation of enhanced recovery, incorporating multimodal and opioid-free analgesia. What is the impact on that enhanced recovery? What is the impact on outcome? So this is where they looked at what is the impact of opioid prescribing practices at discharge. So in other words, if you implement an enhanced recovery protocol, you would reduce the opioid use, but you need to focus on that continuing attention on patient prescription beyond recovery room. So let me show you the result from this study. So they implemented an enhanced recovery protocol in this institution. They managed to reduce opioids. And you can see on the left-hand side, intraoperative opioid use was significantly reduced after the launch of enhanced recovery compared to before enhanced recovery. But then they didn't pay attention about opioid prescription beyond discharge. So they focused a great deal on the intraoperative opioid reduction. But you can see that unless you change prescription habit, the use of opioid prescription at discharge would not be affected. And that is where the real opportunities are, because you have done the good work to reduce opioid intraoperatively, but beyond that, you have to educate the healthcare practitioner, residents, physicians, to not prescribe opioid as we traditionally do, large amount of opioid beyond discharge, 30, 60 days of oxycodone, Vicodin. Those are what we used to do, but starting going forward, we have to pay attention to how much opioid do we give patients beyond discharge. So they found that although they were able to reduce opioid consumption intraoperatively, but 72% of patients with low pain score is So these patients really do not need opioids. They were still given opioid at discharge. So patient can be exposed to opioid at different time points along the surgical continuum, and we just need to pay attention, not just intraoperative and early postoperatively, but beyond discharge, every single step of the surgical journey. Okay, so let's take a look at what drugs are available to us as a non-opioid analgesics. Well, if you think about how pain is being transmitted from the periphery, where the surgeons make an incision, travel along the peripheral nerve to the spinal cord, and then from the spinal cord going up to the brain. So at every point along that pain transmission pathway, there are drugs that are effective in blocking that pain transmission. For example, in the peripheral surgical site, non-steroidal, we know works there, coxips, such as celecoxib, COX-2 inhibitors, anesthetic, local anesthetic, and also block the sodium channel along the pain transmission pathways. And then you go up further up to the spinal cord and the central nervous system, where other drugs work effectively, acetaminophen, calcium channel blockers such as gabapentin and pregabalin, alpha-2 adrenergic agonists, clonidine, dexmedetomidine, NMDA receptor antagonists such as ketamine or magnesium. So there are many different options that are available to us as a non-opioid analgesic techniques, more of a prevention of post-operative pain rather than waiting for the pain to, in a post-operative period, to treat it. So when you are implementing an opioid-free ERAS protocol, what have we learned from our experience? And I think there are really three key learning objectives, or learning the experience from early report of ERAS. So number one, it's important to set patient expectation, that the patient need to understand that the aim is not to have 0 out of 10 pain. The aim is to manage their pain using non-opioid techniques, and not only to understand the short-term benefit, but also long-term benefits. An opioid-free anesthesia alone may not reduce opioid exposure in the post-operative periods. So we need to incorporate other ways to trying to manage these patients' pain. And lastly, opioid-free enhanced recovery is possible. There are many procedures now where you don't really need opioids. For example, if you are doing a peripheral limb procedure, knee replacement, hip replacement, where you can do a peripheral nerve block, whether it's a ductal canal block or spinal or epidural, you don't really need additional opioids because the pain signal is completely blocked from the surgical site. So opioid-free anesthesia is certainly possible. Smaller procedures, abdominal procedures, lap chole, hernia, again, there are different blocks that can be done. The TAP block works very well. And when the block works well, it minimizes the amount of opioids that you need to treat these patients. So in summary, the use of opioid traditionally in the perioperative setting has really contributed to this opioid epidemic that we see today. Now, even though we got a lot of different options for pain management, pain is still an issue, and we see that every day in our patients, in particular those who have severe and extreme pain. Every day goes by, you will see patients in the recovery room agonize in agony because they have post-operative pain. I think we've got to have a better understanding of how can we use non-opioids to manage patients' pain more as a foundation, and use opioid-sparing and opioid-free approaches within the context of enhanced recovery protocol to better manage pain. And I think implementing an opioid-free enhanced recovery program is possible, but it does require a teamwork. It does require not only anesthesiologists, but surgeons, the nurses, physical therapists, pharmacists, and also, importantly, hospital administrator, all come on board to say that this is important, we want to implement this, we need the institutional support. And that is how an enhanced recovery program can be successful. All right, so lastly, I just run through with you one of the enhanced recovery protocol that we use as part of an enhanced recovery program. So this is a colorectal protocol divided into pre-op education. As I said, one of the most important is education. The patient need to understand what would happen to them. What is their expectation? That if you tell them that post-operative day one, you should be up and about, you should be starting to eat and drink, and they expect that. And you can tell them about pain management, how are you managing their pain? So those are important. And there are some programs even making sure that the patients, when they come for surgery, their nutritional status is optimal, so you may need a nutritional consult. They want to make sure that they are not MPO for 12 hours, which we traditionally have done. There is no reason to keep the patient MPO for that length of time because they get dehydrated and they are hungry, and so they don't do well in a fasted state. Bowel prep in the context of colectomy, again, the pendulum seems to swing from one end to the other. Currently, there is evidence that limited bowel prep with antibiotics seems to produce the best outcome, and we give our patient carbohydrate drink the night before and the day of surgery, and we say that you can drink clear fluids up to 2 hours before surgery. Then obviously for prevention of infections, we carry out a number of infection prevention strategies, including cohexidine shower, getting the patient educated about their colostomy post-op. As I mentioned earlier, we give carbohydrate drink, we check the blood glucose, and in fact, current evidence suggests that even for a non-insulin dependent diabetic, it's still beneficial to get a carbohydrate drink. What about pain management? Well, we give patients preoperatively either IV acetaminophen or COX-2 inhibitors. We give them gabapentin, this is a calcium channel blockers. And intraoperatively, we keep the patient at the right level of anesthetic level. We're using brain monitors to keep the bispectral index between 40 and 60. We try to do as much peripheral nerve block or epidural, and then for the context of colectomy, for the open colectomy, we use an epidural. For laparoscopic, we use either a spinal or a TED block, because when the epidural works well, you don't really need to give any other opioids intraoperatively. So at the end of the case, we use non-steroidal. We continue to use IV acetaminophen until the patients started to eat and drink. IV antibiotics, as is fairly standard routine, we give them prophylactic PONV, post-op nausea and vomiting prophylaxis. The common drug we use are scopolamine patch, dexamethasone, which is a steroid, and ondansetron at the end of the procedures. And then we manage fluid very carefully, because it's another area that we don't do a good job. We tend to give patients too much fluid, and so we put our crystal infusion on a infusion pump, give it at about 3 to 5 mils per kilo per hour. of ideal body weight, and we use a cardiac output monitor to monitor patients' plasma volume, cardiac output, so we don't inadvertently give patients too much fluid. We take the tubes out as much as, all the tubes that can be taken out. We don't leave any drains in. We take out the NG tube, and then post-op day 0, in the morning they have surgery, in the evening we're trying to start them to have clear fluids. The next day start to introduce semi-solid diet and then move on from there. So you can see very early on the patients re-establish their oral regimen, because the earlier you can have the bowel function, the higher likelihood of the patient being discharged from the hospital. Continue to pay attention on fluid, convert the patient from IV to oral as quickly as possible, discontinue a Foley catheter, and we usually take out the epidural as soon as the patient is up and about, and establish an oral regimen. Pain management, continue to focus on that IV acetaminophen until when they start to eat and drink. Continue gabapentin, continue celecoxib, and use opioid as a breakthrough pain rather than as a foundation or prevention of pain. And again, trying to get them out of bed as early as possible, trying to get them to have a good night's sleep, trying to feed them as early as possible. So those are the really 3 key things to try to get the patients recover as quickly as possible. So with that, I want to thank you for your attention over the last 40 minutes or so, and I'm delighted to take any question or comment, and thank you very much for your attention.
Thank you, Dr. Gann, for that fantastic presentation. And as a reminder, today's session is being recorded, and you can use the same link you used to log into today's webinar to access the recording. Beckers will also be making slides available via email. And with that, we'll begin today's question and answer session. Please submit any questions you have by typing them into the Q&A box you see on your dashboard, and we'll try to get through as many questions as we can. The first one we'll take is, did the use of esmolol affect opioid use after 3 to 5 days post-op?
Yeah, that is a good question. Typically, esmolol use reduce more within the 24 hours post-operative opioid use. Now, esmolol does have some analgesic property, reduce opioid consumption, but it doesn't last very long. However, we also know that beyond 24 hours, and especially 48, 36 hours, the amount of opioid most patients use tend to decrease anyway, as pains get less and less over the post-operative period. But I think esmolol, and along with other drugs such as alpha-2 agonists, non-steroidal, IV acetaminophen, they all reduce opioid usage anywhere between 15 to 30 to 40%, depending on the surgical model. The more painful procedures, you tend to have a greater effect of these non-opioids, such as total knee replacement, which is extremely painful. And you often see, for example, a study show that IV acetaminophen reducing opioid consumption up to about 30-40%.
Thank you, Dr. Gann. And the same attendee has a follow-up. Do you use cardiac output monitor on all colorectal ERAS patients?
Yeah, that's a good question. So let me tell you, and my use of cardiac output monitor has evolved over the years. In the study that we published in 2014 or 15 now, where we did colorectal enhanced recovery patients, we use cardiac output monitor in every single patient. and that would include both open colectomies and laparoscopic colectomies. And the reason we did that was because we didn't want to have too many different diverging protocol, because that is add to confusion. So we decided that for this enhanced recovery protocol, which is the protocol is complex enough and you don't want to add further complexity, and we decided that everyone should get a cardiac output monitors. And with that, we showed a reduction in crystalloid use by about 30%. Blood loss was less, and the post-op complication was also lower, which again, this has been shown in many other what we call goal-directed fluid therapy study. And if you look at data, most of the data that show that in enhanced recovery protocol, if you want to manage fluid well, you really need to have a monitor that tells you where you are in terms of your fluid status. And again, for minimal procedures such as cholecystectomy, minor abdominal procedure, I don't think there is a good evidence to suggest that the use of cardiac output monitor benefits these patients. But any of the more larger abdominal procedure, especially those which have a higher blood loss or unpredictable blood loss, then I think the use of this monitor will add value. Now, there was a editorial that we published a number of years ago that really trying to guide clinicians on what are the criteria where one would want to use a cardiac output monitors. Now, there are essentially, really, if you think about it, there are two important factors to consider. And one is what we call the patient factor. The other one is the procedure. So if you think about, if you have a fit, healthy patient, and let's say, for example, you draw a graph, on the y-axis is the procedures, or the extent of the procedure, how extensive it is. On the x-axis is how sick the patient are. So the further beyond the zero line where you have sick patients and extensive procedure, then I think enhanced recovery, cardiac output monitor, I believe, is a beneficial monitor, and it actually reduce complication and reduce cost of overall hospital stay. And as the procedure gets smaller and then the patient gets younger, fitter, then I think the value become less. So the way that I manage it is that for sicker patients and for a larger procedure, this is where I think the cardiac output monitor will help, because we don't really have a good way to tell us where we are in terms of patient's hemodynamic status. And I think that often we get it wrong. Now, reducing fluid, and over the years we have reduced crystalloid use. I think that has helped because we produce less interstitial intestinal edema, and that reduce the length of bowel recovery post-operatively. But often we don't know, because if we restrict too much of fluid, the patient may then have an increased risk of complication as well, in particular acute renal failure. And studies have shown that if you give too much, you get more complication. If you give too little, you also increase the risk of complication. And that the U-shaped curve that is traditionally shown for fluid management, what we want is not too much and not too little. And unless you have a monitor to monitor objectively, it's tough to know where you are in that U-shaped curve.
Thank you for those insights, Dr. Gan. The next question we have here is, what kind of tools do you use to manage, track, and audit implementation of protocols during patient care pathways?
Right. Great question. And I think that one of probably the most critical element of success or failure of enhanced recovery is whether you audit your data, whether you collect your data, because unless you have a good audit mechanism and system, if you don't get the results that you desired, one has no idea whether is that because I did not implement all the important elements, or because the elements just didn't work. So unless you know that, it's difficult to know where can you make it better. Give you an example. A few years ago, there was a study, and there's a very elegant study, where they started an enhanced recovery protocol, and they produced great results. And they also collected the how many elements do they implement, and they found that of all the elements that they was in the protocol, they implemented about 80% of the elements, and they produced a reduction in length of stay by 2 days and lower complications. And then 6 months after the enhanced recovery protocol was launched, and they begin to see that their length of stay creeping up. They begin to see their complication rate creeping up. And then they were saying, oh, wow, why was that? Because we implemented enhanced recovery. And then they restarted to look at the audit and then look at what is the number of elements or percent of elements that was actually done. And they found that over the 6 months, the number of elements that was actually done decreased from 80% down to about 40%. At the same time, the result they saw was not the result they initially got. So the length of stay has crept up, complication went up. And then they made a second attempt to trying to increase the compliance of these elements. And they were able to get back to 70-80%, and then they saw a improvement of their outcome. So unless you have an audit system, it's difficult to know that. And therefore, I would say that we use a system, and again, every institution may be different. We try to build it within our EMR system. So in other words, all the elements, we try to make it as part of the nursing, their day-to-day activity. For example, let's say multimodal analgesia, we have in our order set that these are the medications as part of enhanced recovery protocol. And when the nurses give this medication, it's automatically tracked within the EMR. So that make it less time consuming for someone having to abstract the chart to see what was actually given. And when the patient started to eat and drink, that was also as a data point that was entered by the nurse, and therefore one can track the various elements of interest of enhanced recovery. So great question, and it's an important one that one needs a good audit system.
Thank you so much, Dr. Gan. And this next question is asking for, I believe, a clarification about some information on slide 21. So the attendee asks, is it a decrease in actual opioid prescriptions with multimodal approach, or a reduction in dosage of opioids in 24 hours?
So, yeah, typically what you will find is that there is a decrease in the amount of opioid that a patient would need. At the same time, when you reduce the opioid consumption, you also result in a reduction in opiate side effects. So as I just reviewing slide 21, I don't know if you can see it here. So you can see here it reduced GI complications, reduced respiratory complications, reduced opioid prescription. So typically it's the needs for opioids. So in this case is whether they need opioid or not. So in other words, fewer people need additional opioid once you have a enhanced recovery protocol.
Thank you for that clarification. And the next question we have here is, what do you suggest for post-op discharge medication, if not typical Percocet or oxycodone?
Yeah, so it depends on the type of surgery. We have, if you are having a small, relatively minor procedures, we have given patients a non-steroidal ibuprofen as their rescue. And often we find that patients don't need opioid as rescue. In fact, for certain procedures, especially orthopedics, procedures, it's mainly inflammation, as we know, that cause pain. So if you have a good anti-inflammatory, it may be adequate. And I can tell you that many patients, when they are given opioid as a rescue, they take one dose and they get all the side effects. And they say, wow, that is enough. I'm not going to take further opioid. And guess what? They then take non-steroidal as their rescue during their post-op recovery period. So I think there are many procedures where we can use drugs such as non-steroidal. And in fact, I usually, for the smaller procedure, advise patients to take alternating non-steroidal and acetaminophen because they work on a different mechanism, and they both have, again, they are not the strongest analgesic, but they both are synergistic, and if you take them together, you can maximize the amount of pain relief, and often you can avoid using opioids.
Thank you so much. And the next question we'll go with, I think, this attendee is looking for some research articles. So they're wondering, are there any research articles that have monitored the success of the protocols?
There are some papers out there, and I think I described to you about that study where they track the elements of enhanced recovery and found that unless you reach about above 70% of the elements of enhanced recovery, that you will start to see a beneficial effects of enhanced recovery. If you are hovering about 40-50% of compliance, often you don't see the results. And that's why I think it's important to track those elements of enhanced recovery. Now, I would also say that, depending on the enhanced recovery protocol that you refer to, some of them have many, many different elements. I would say that there are what I call the critical elements to adopt, and there are sort of nice ones to have. Those critical ones are things like multimodal analgesia, is critical, prophylaxis on post-operative nausea and vomiting, fluid management, minimally invasive surgery, so that if a surgeon can do this under laparoscopic, by all means, trying to feed the patient as early as possible, trying to get the patient out of bed as early as possible. Those are really the critical elements of enhanced recovery. And in fact, Hendrik Kellett, who is the pioneer of enhanced recovery, and he published a paper about 20 years ago and adopting an enhanced recovery protocol, incorporating those elements that I mentioned earlier just now. They saw a significant improvement in post-operative care. So those are some of the critical elements. There are a few others like, getting the carb drink, those are sort of nice to have, but I think the key are really those things that I mentioned, and you would likely see beneficial effects if you adopt those elements in your enhanced recovery.
Thank you so much, Dr. Gan. And as we're just nearing our end of time, I'll just ask you if you have any final thoughts you'd like to share with attendees today.
I hope that this has been helpful, but I would say to you is that, in my experience, this has been very rewarding. I know that every hospital have interest in having people to lead teams to adopt enhanced recovery, whether you are anesthesiologists or surgeons or even nurses and, pharmacists. We all can come together to say, how can we program the best care for our patients? And often this is not only improving patient care, it reduces the healthcare costs. The hospital administrator would be very excited if you go to them and say, this is we're going to try to help to increase value, and which is really the key value is to increase quality, reducing cost. So I would urge you to, if you don't have an enhanced recovery protocol, go to the hospital, get the team together, implement it. It's hard work, but you will find that the reward is very satisfying.
Thank you so much, Dr. Gan. And that's all the time we have for today. I want to thank you again, Dr. Gan, for your excellent presentation, and Mallinckrodt Pharmaceuticals for sponsoring today's webinar. Everyone enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thank you very much, Brian, and thank you for everyone who listened today.